Good morning to all. Thank you very much for your time and effort to attend this talk on surgical management of kidney stones in children. I've made it a very comprehensive talk so as to save your valuable time. So talking about renal stones, I just need to acknowledge Dr. Shripati, who initiated me and asked me to start doing stone work. And this is Dr. Elizabeth Daly from the Sydney Children's Hospital, who taught me the basics of managing endourologic management of renal stones in children. The overall picture with renal stones, there has been a dramatic increase in the incidence of pediatric stones, and assessment of pediatric stones includes identifying the density, the nature of the stone and the anatomy of the renal tract. All kids presenting with renal colic and suspected renal stone should initially be worked up with an ultrasound. Though helical CT is the gold standard, it should be avoided unless we are suspicious of more stones, missed stones in the renal tract, mainly in the upper tract. And recently, the advent of smaller scopes has made pediatric ureteroscopy commonplace, with the success matching those of adults. And upfront, renal stone management should always involve a pediatric nephrologist right from the beginning of management, rather than after the child comes back to you with recurrent stones. The surgical options available for stone management are extracorporeal shockwave lithotripsy, mechanical lithotripter, or intrarenal surgery using a flexible ureteroscope and laser technology, percutaneous nephrolithotomy, which is called PCNL, and lastly, open or laparoscopic surgery. The recent American Association guidelines have been discussed here in a gist so as to sort of have in a nutshell the overall stone management. Uncomplicated ureteral stones can be observed. Uncomplicated ureteral stones can be observed with or without follow-up ultrasounds. Asymptomatic non-obstructive stones should be followed up by pediatric ultrasounds. Sorry, I just need to go through this quickly again. So uncomplicated ureteral stones of less than 10 millimeters should be observed with or without alpha blockade. And asymptomatic non-obstructive stones may be followed up by periodic ultrasounds. When the stones are slightly bigger, but still non-obstructive and asymptomatic, in our clinical practice, we tend to wait for a maximum of 2 to 3 weeks, especially if they are placed in the pelvis or in the upper ureter. Sometimes smaller calyceal stones may be still observed till they sort of migrate their way down to the pelvis and the ureter. Ureteroscopy or short-wave lithotripsy should be offered when the stones are unlikely to be passed after having waited for more than 2 to 3 weeks, or if the symptom is persistent. As far as symptom is concerned, in my practice, I wait for 24 hours for the renal colic to subside. Renal colics can sometimes be very painful. Yes, by patiently waiting for another couple of days, the symptoms may still reduce, but it's very distressing for the child and the parents to have a severe renal colic for more than 24 hours. As we all understand, the pediatric renal tract, or the ureters, the vesico-ureteric junction, the ureters and the kidneys are a miniaturized version of the adult renal tract, and sometimes we may need to place a double J stent prior to doing any procedure. The stents are generally left in situ for a couple of weeks so that the ureters and the vesico-ureteric junction dilates and provides enough space for our instrumentation to happen. But stents need not be routinely placed in all cases prior to ureterorhinoscopy, especially in kids, in any kid for that matter, generally kids over 2 years. I try to get inside with my smallest ureteroscope, and if the ureteroscope is able to negotiate the renal tract, you need not do a pre-stenting. In stones less than 20 millimeters, short-wave lithotripsy or ureteroscopy should be the first line of therapy. In my practice, short-wave lithotripsy is not useful for stones over 1.2 centimeters. In bigger stones, like greater than 20 millimeters, short-wave lithotripsy does not work generally, and ureterorhinoscopy may take too much of time. So percutaneous nephrolithotomy, where the stones are broken by direct access to the kidneys, are advocated. And excepting in cases with coexisting anatomical abnormalities, laparoscopic or open surgery should not be routinely done. The AUA guidelines suggest that mechanical lithotripsy should never be used as the first line modality. Rather, they are suggesting use of laser technology. But in our clinical practice, we use mechanical lithotripsy quite frequently. I will tell you the advantages as soon as we reach the topic of discussion. And an important caveat is that in children with obstructing stones and suspected infection, the collecting system, that is the renal tract, should be urgently drained. See, it's either by means of stenting. So suppose the child has got an infection, comes to you with a renal stone and a secondary sepsis, especially in urosepsis, the first priority should be to make the tract patent. You know, like you pass a stent, facilitate the drainage of urine. And suppose there is pus in the renal tract, it might be worthwhile, you know, removing the pus by percutaneous aspiration or by drainage before we go and try to break the stone. So the first modality of management, which is the simplest for the child, is extracorporeal shockwave lithotripsy. It is generally used for soft stones which are less than 1.2 centimeters, which are localized in the upper tract, that is the calyces, renal pelvis, or upper ureter. Though the AUA guidelines suggest that it can be used at all levels, in our practice we have found it to be very hard. It basically involves stone fragmentation by use of shock waves. So this is the piezoelectric crystal which delivers the shock waves. This is the patient. The loin of the patient is in contact with the water bag here, through which the shock waves are transmitted. ESWL, particularly in children, is done under the general anesthetic, and we also use image intensification to locate the stone. So once the stones are broken, the stone fragments pass through and are spontaneously expelled. Though stenting is advised only for larger stones, sometimes we have found that the pre-procedural placement of the stent facilitates quick exit of the stones. Now, the advantages of ESWL is non-invasive, but kids still require general anesthesia. Stones size is generally less than 1.5 is what is recommended, but in my practice over 1.2 is very difficult to clear by ESWL. Stone free rates are higher with the proximal stones than in the mid or distal stones. It is more effective with the soft stones, and where the stones can be localized by X-ray. Say for example, calcium stones make the stones radio opaque. Stones and ultrasound, the uric acid stones can be recognized. The radiolucent stones, such as cystine stones, will be two things. One is it will be very hard, and it will be very hard to localize the stones for breaking while doing an ESWL. Now, you might wonder why such a simple procedure, apart from size of the stones, as you would have noted in your clinical practice, all of us get generally smaller stones in Indian kids. Why not uniformly do ESWL for all the cases? Now, ESWL, you can never be certain that the stone is completely broken. In smaller kids, especially in kids less than 2 years, it's very hard to sort of localize the stone without causing damage. Apart from the direct damage, something like renal damage, including perirenal hematoma, hematuria, sometimes hypertension and obstruction as well with the broken strand fragments. Lung contusions are also reported with the pediatric stones, especially in smaller kids. It is contraindicated when there is a PUJ or a VUJ obstruction. In immobile kids who very commonly develop stones because of their sedentary or lack of mobility, like kids with scoliosis, it's very hard to sort of position the kids for the stone for the ESWL. As I mentioned earlier, it's less effective when the stones are hard. Calcium oxalate, there are both hard and soft stones in calcium oxalate. The harder stones cannot be broken, as well as the calcium hydrogen phosphate. That is the stones you get in renal tubular acidosis. Now, coming on to the second modality, the one that is most commonly used, at least in my clinical practice in children, is mechanical lithotripsy. It is a method of directly visualizing the stone in the urinary tract using a rigid ureteroscope, and there is simultaneous application of energy. The energy is applied. This is the lithoclast. This is the conventional lithoclast. The lithoclast is basically, this is how you set the pressures in the lithoclast. The pressure is this lithoclast. The energy source in the lithoclast is an oxygen cylinder, or you can directly connect it to the theater oxygen supply. But you need to control the pressure up to 4. So any pressure over 4, the pressure might be a bit too much for the renal tract, and you can set the lithoclast to fire at a particular speed. You can have a single shot, you can have a medium number of shots, and it can go really fast. So the lithoclast mainly works through a stainless steel probe that is passed through the working channel of the scope to fragment the stones. It's a very, very economical means of fragmenting lower ureteric stone. Now, this lithoclast costs around 35 to 50,000 rupees. It's very safe to use. It can be used for 10 years altogether, and all the probes are reusable. As compared to a laser, which I'll be discussing later, with the laser unit, it's by itself costs 25 lakh rupees, and the fiber is again, the laser demands a separate set of equipment, which is again more expensive. But I limit my lithoclast to just the lower ureteric stones. Stones in the upper tracts are large and hard stones, though it is recommended to be used in hard stones. I found that any stone over 1 centimeter, particularly if it's hard, it's almost impossible to break with the lithotripter. Now, these are the scopes, the ureteroscopes. I use 2 sets of scopes. One is the 6.5 French scope. The second one is the 4.5 French scope. Now, both of them in children, 330 millimeters, 33 centimeters, as compared to adults, which are 45 centimeters. So this is a stone undergoing a mechanical lithoclast, lithotripsy. So as you can see, the stainless steel probe is basically, there is a jackhammer effect. It is just mechanically pulverizing the stone. So if you are in the theater observing this procedure, it will appear as if somebody is trying to break a rock with a jackhammer. So as you can see, this is an obstructive stone with plenty of edema around the ureter. Generally, once the stones are broken, previously I used to retrieve with a Dormia basket, but my current practice, I don't retrieve the stone. I completely break the stone into smaller pieces, and I use a stent. I leave a stent inside too, so that the stones can be passed out. Now, coming to the next higher level of management, it is retrograde intrarenal surgery, which is otherwise called RIRS. I'm really passionate about RIRS because RIRS in pediatric practice is capable of breaking at least 99% of the stones, excepting for the very huge and hard stones in the renal pelvis, like the stag-on stones. Now, RIRS is defined as method of reaching the upper renal tract through the ureter, involving use of rigid and flexible scope and laser energy for stone dissolution. So basically, we make use of this flexible scope through the vesicoureteric junction and pass it through the upper tract to retrieve the stones. I prefer using RIRS for upper ureteric stones, renal, pelvic, and calicine stones, particularly if they're less than 2 centimeters. It is usually helped by image intensification, that is an X-ray machine, fluoroscopy, while we pass the scope to locate the stone and the scope. Though we have direct vision, IA is a prerequisite for doing a laser lithotripsy. The option for stone fragmentation is the laser machine, which is the center point of all this action. The current laser that is used is the HOLMIUM YAG laser. The size of this scope is 7.5 French. So in children, before I do a laser lithotripsy, I pre-stent all the children. Though in adults, pre-stenting is not recommended unless you are unable to pass the scope. It's got a very high success rate of about 92%. It still depends on size of the stone. But if the stones are very large, it's better to do it in multiple procedures. But I never do multiple procedures. If the stones are very hard, upfront I recommend percutaneous nephrolithotomy for them. Now, the limitations of this pediatric RIRS. I will show you the scope in the next picture. The pediatric male urethra is quite small. We can maximum accommodate an 8 French at a time. The ureteric orifice is even narrower. As you would know, the size of the ureteric orifice is it's sometimes 4 to 6 French. Sometimes even 3 French ureteric catheters don't pass through. So upfront, you may not be able to do an ureteral or RIRS without pre-stenting. However, with the recent miniaturization and durability of the endourologic exam instrumentation and the acceptance of the YAG laser for use in kids. The laser has, though it sounds very interesting and advanced, it has got its potential disadvantages. You cannot use a laser for a prolonged period because of the associated tissue damage. But because of evolving use in ureteroscopy and the acceptance of laser use in children with the continued research, the ureteroscopy with the RIRS is an attractive option in young children. Now this is the scope that I have mentioned previously. This is a long ureteric flexible ureteric scope. It's 7.5 French in diameter. The working length is 67 centimeters, and this is the working channel through which we insert the laser fibers. And this is the laser, the point of interest. This is the HOLMIUM Nd:YAG laser. So yttrium aluminum garnet, that is the crystal, that is the particular crystal that is present. So as you all know, laser emits photons. The photons are converted into energy to act on the particular area of interest or the tissue. Now the HOLMIUM, as you all know, is a rare metal. It amplifies the effect of the Nd:YAG laser or the photon activity. So once the photon activity is transmitted to the particular stone by means of a laser probe, which transmits the photon energy. And the photon energy, what it does is that it causes vacuolization of the water between the probe and the stone. Once it vacuolizes the water, these water vacuoles are the one which transfer the energy to the stone and they pulverize the stone. So this is the setup. This is the smallest child that I have done a laser lithotripsy. This is an 1.5-year-old child. I reckon this is a lower ureteric stone, and this is the laser theta setup. So that is the laser. This is the flexible scope inserted into the urethra. As I mentioned previously, it is always done under image intensification. So this is the full theta setup. This is a different, this is a bigger child. This is an adult child done a different case. So this is the way the surgeon is positioned at the foot end. The scope gets inside the urethra, and you have both image intensification and good vision with a good set. So this, I think, is a store set. So initially, as I mentioned, all the patients are pre-stented. Once we remove the stent, instead of getting the flexible scope in upfront, I do a rigid ureteroscopy just to check what is happening to the urethra and whether the flexible scope can enter the ureter without difficulty. If I think that it will be hard, I sometimes leave the stent for some more time. And this you can see is the upper tract stone. Now, once that is sorted, the next step is to insert the guide wire under ureteral access sheath. Now, this is the ureteral access sheath that is getting inserted. See, basically the ureteral access sheath is a device which can accommodate the scope. The flexible scope is it's a very fragile instrument. And secondly, it can, it can keep moving. So the ureteral access sheath that's used here, they were basically invented to sort of give some sort of rigidity to the scope as you're pulverizing the stone. But in my contemporary practice, I've done away with the ureteral access sheath and I insert the scope directly. This is because the ureteral access sheath is a big rigid sheath. Two things. One is it may be hard for pediatric ureter, especially like kids like the one that we had around 1.5-2 years. So those kids will find it very hard to accommodate the sheath. And secondly, so this is the ureteral access sheath. So secondly, it can cause some damage to the vesico-ureteric junction. So I do my insertion of the flexible scope over the guide wire by avoiding the ureteral access sheath. But the IA is mandatory. Intensification is mandatory. So you reach the stone under image intensification, done under direct vision, and only when you reach the stone, you start connecting to a camera and then pulverizing the stone. Now, coming next to the laser setting. Laser settings are various laser settings which are necessary depending on the stone configuration, and there are various sizes of the laser fiber depending on the location of stone. I will not go into detail at this stage. Now, breaking the stone at last. Now, breaking the stone, now basically huge stones, initially, suppose you try to fragment the stone upfront with a very high laser energy, the stone fragments will keep moving around. It becomes very hard. So at the start, what we do is this procedure. This is called as dusting, where we try to chip away the stone. So the laser is kept at a low energy and high frequency. As you can see, the laser is just painting or dusting the stone. So it basically makes it into a small stone. So once that is achieved, so as you can see, it has almost pulverized the stone, but still fragments are left. And the next step is to use a high laser energy at a low frequency. So this is called fragmentation. As you can see, the fragments keep flying around, but they are small fragments. and in a limited ureteric space, they'll keep coming back to your, they'll retropulse and come back to your fiber. So the next video is the child that we did, that I showed up front, the 1.5-year-old with the lower ureteric calculus, the lower pole, lower calyceal stones are particularly hard. That's because of the angle of entry, but still it can be achieved. As you can see, the stone is getting pulverized. The scope is at an acute angle when we are trying to enter the calyx. See, suppose there is a very huge stone in the lower calyx. Upfront, without suggesting a RIRS, we can suggest for a percutaneous nephrolithotomy. RIRS, yes, it's not without complications. Complications is the safest modality of endourology for difficult stones. Its complications are a little uncommon in experienced hands. But perforation of pelvis, ureter, and calyx have all been reported. I have had small perforations which have healed spontaneously. The bleeding aspect is less common than with the percutaneous nephrolithotomy, but sepsis and retained stone fragments are definitely reported as in all the other managements. Complications generally happen as in any procedure in surgery if the technique is poor or if the access sheath is too large. That's why I've done away with the access sheath and long laser settings. I thought discussing laser settings is beyond the purview of this meeting. And lastly, trying to repeatedly pass the scope in and out to retrieve the stone. So for large stones, this is what is recommended. I don't do percutaneous nephrolithotomy. The reason is in the center where I trained, though the stones were broken successfully, I found that the morbidity of the procedure was very high in the post-op, like bleeding and retroperitoneal hematomas and ileus and sepsis in children, because basically the size of the kidneys is small, and kidneys in percutaneous nephrolithotomy, basically the child is positioned on his or her back and the kidney is accessed directly like this by means of this gadget called as a nephroscope. These are bigger scopes and these are accessed, the access is through the lower calyx. You directly visualize the stone and break it. It is not without its advantages and disadvantages. It's usually done in the prone position. As I mentioned before, it is done for bigger stones over 2 centimeters and hard stones like cystine stones. Sometimes lower pole stones may be very hard to access by any other method, so it's better to do it with a PCNL. So stone-free rates are very high with PCNL because of the direct visualization and high energy source. But it's not without its complication, as I've said before. Post-operative bleeding and hematuria are more common than in the retrograde intrarenal surgery. We definitely need to leave a stent in post PCNL. It has got a longer hospital stay, at least 2 to 3 nights, and the risks of GA in a prone position, especially with a smaller child. Now, lastly, coming to open and laparoscopic surgery, it is done only in a very the current management is it's done only in a very small fraction, about 5% of the pediatric stone population. Now, in my practice, bigger stones, if anything over 2.5, especially if it is a staghorn stone. When you say staghorn is a stone that takes up the size, takes up the shape of the kidney. It basically takes up the shape of the pelvis and it goes on to the calyces, like a staghorn. So basically, those stones are very hard to break. It's very hard to enter in with the nephroscope. Very hard to do any urologic procedures, and it takes a lot of time. So those are the kids I prefer to sort of use open or laparoscopic surgery to remove the stone. The stone-free rates are higher this way in if the case selection is right. Now, comparing the various options for upper tract stones. So ESWL advantages: it's non-invasive. We need it for very small stones. You don't need to use stenting. Stone size up to 1.2 centimeters. The stone clearance rates are slightly less. Stone composition is important for ESWL. Complications, as I mentioned before, you can get a stone colic, you can get renal hematomas and lung hematomas as well. Now, between RIRS and PCNL. So RIRS is basically meant for smaller stones up to 1.5 centimeters. They can be hard stones. They can be at any part of the renal tract, excepting for difficult stones in the lower calyx. Complications are less in experienced hands, which is usually sepsis, ureteral damage. Now, PCNL indication is for hard stones above 2 centimeters. The stone clearance rate is very high, but as are the complications like sepsis, injury to surrounding viscera and obstruction as compared to the RIRS. Now, to conclude, stones are becoming increasingly common in children. The commonest stones that we see in our practice are idiopathic stones. In the Western setup, I've seen plenty of metabolic stones. I've seen plenty of metabolic stones, in which are usually like very hard and like have multiple procedures. Our stones are generally idiopathic. ESW is indicated in small stones. Lithotripsy, even the mechanical one, is economical and safe to use for lower ureteric stones. RIRS is used for stones in the upper tract with good stone clearance, whether hard and soft stones. An ideal case selection. Large stones should be preferably managed with PCNL or nephrolithotomy. And as I mentioned, pediatric nephrologist involvement right from the start for metabolic workup and follow-up is very essential for pediatric stone management. Thank you. I'm happy to take the questions. So if you can kindly send your questions to the chat box. Are there any questions at all, or my presentation was so clear and awesome that it has completely clarified stone management in all our minds? Just unmute everyone. So let us see if somebody is interested, they can ask questions. Yeah, in case you want to ask, have any questions you want to ask directly, you can happy for you to unmute your video and switch on your video and ask me. Now, yeah, I think before all of you leave, since we've got few minutes more, not much of discussion, I can tell you in short about the types of stones. I am sure Prahalad would be an expert with that, but the types of stones that we see, the commonest stones that we tend to see in our clinical practice are the oxalate stones. Oxalate stones, there are two types of stones. Oxalate stones, there are calcium oxalate monohydrate and calcium oxalate dihydrate. Now the monohydrate are the harder stones and the dihydrate are the softer stones. Calcium oxalate stones are commonly idiopathic, like in all other stones in children, but they can be specifically seen in kids with hyperparathyroidism, in kids who have had bowel surgery in childhood. It can be like a short bowel, or it can be a diversion procedure in childhood. And of course, kids who are obese with a lot of salt intake. So the advice after breaking or clearing up the stone for kids is mainly dietary and workup for hyperparathyroidism by the pediatric nephrologist. So the dietary advice, what I'll tend to give them is to reduce the following foodstuffs, which are mainly beetroot, spinach, I would say chocolates, tea, and and all junk food and all sorts of junk food. This is what is advised in oxalate stones, and you work up for hyperparathyroidism. The second one, the calcium phosphate stones. These are hard stones. These stones are generally seen in kids, idiopathic as well, and kids with renal tubular acidosis. So kids with calcium phosphate stone and stone analysis should be worked up for renal tubular acidosis. Third one is the uric acid stones. Now, uric acid stones are can be seen in children who are undergoing a lot of uric acid excretion, like in kids with malignancy and chemotherapy. But commonly in our practice, we see them in kids who have a high metabolic rate, like kids having a lot of sort of red meat and who don't take much of water. They are again soft stones, and importantly, the use of alkaline citrate is it's mainly useful for uric acid stones, because uric acid stones are formed in acidic urine. So this is one indication where alkalinizing the urine will be of sort of much use in the management, rather than routinely alkalinizing all kids with stones. Say for example, calcium phosphate stones, they are formed in alkaline urine. So if you're going to have a kid with the renal tubular acidosis, and if you're going to further alkalinize the urine, it's going to promote the sort of formation or increase the size of the previously existing stone. So on the next one is an struvite stone. Struvite stones are the triple stones, what we call as the famous triple stones. The magnesium aluminum phosphate, they are basically infective stones formed as a result of infection. Usually we find them in the renal pelvis. They're bigger stones. Usually those are the stag ones that we find in the renal pelvis. And secondly, also in the bladder stones. So I thought we won't have much time, and so I left out discussion of bladder stones. Bladder stones are also seen in children. Generally, they belong to the poor socioeconomic group, but now I'm finding them in otherwise in the middle class children as well. Bladder stones are generally huge and very distressing. The colic secondary to bladder stones is very painful when the child tries to pass the stone. And bladder stones are generally mixed stones. They are also idiopathic in origin, but sometimes there can be recurrent infection, which can lead on to formation of the stone. And bladder stone removal is generally, sometimes if the smaller stones are there, you can break it with means of nephroscope or by the laser energy. On many occasions, I find the bladder stones are quite big, and we have either used cystolaparoscopy or open stone removal for good stone clearance. And lastly is the cystine stone. Cystine stones are generally seen in, it's very rare. It is generally seen only in kids with cystinosis. Cystine stones are very hard stones and are recurrent. And they need to be managed metabolically as well, like you manage oxalate stones and hyperparathyroidism, and like with the calcium phosphate stones which are formed in renal tubular acidosis. All these metabolic stones, metabolic management of these stones is of paramount importance, apart from the surgical management, which is mainly meant for anatomical problems and obstruction. Right, I think that ends my talk. Hopefully, I've given you a gist of stone management in children and made it worth your time. Thank you very much.